Okay, everyone, we're going to get the last session started. As promised, we have more on incentives in this session, and we're going to start first with Tyler Erath. Tyler is a VCBH training program graduate and a now assistant professor in the departments of psychiatry and psychological science here at UVM. And he's going to be talking about expanding access to contingency management for stimulants and other substances in syringe services programs. Tyler.
See how high we can get this mic to go.
Next there, don't forget that.
You can get it back down. I'll help you. So I wanted to just start with an acknowledgement and really a note of thanks for the collaborators who have made this research possible that I'll be talking about today. And just more generally, it really is a privilege to be up here and be presenting in a contingency management session. When you look at the session, the fact that there's Steve and Maxine that are presenting after me, who are the pioneers and my idols, it's just really an honor to be up here talking about contingency management. And thanks to Steve for the years of being able to learn and figure out what all this is about and then where I can fit in to try to expand CM moving forward. Disclosures, nothing to disclose for these purposes. And then listed our current sources of funding, which include work with the Vermont Division of Substance Use Programs on contingency management implementation as well. So something that Jack noted yesterday in his keynote, and that's been touched on a little bit throughout these presentations, is what drug use patterns look like here in the United States and how it really is ever evolving and just always changing. And I just wanted to start out with some epidemiological data that really speaks to this. So oftentimes we think about this fourth wave of the overdose crisis as an opioid or a fentanyl crisis. You'll read a news article talking about the opioid crisis. And that's clearly, that's what these data show, extensive data over the last couple of decades from the profound damage of opioids, so prescription opioids to heroin to fentanyl. And then really looking at fentanyl over the last few years of how it expanded the scope of the number of overdose deaths that were occurring. So if we look here in 2015, there were about 52,000 fatal overdoses. And in less than a decade, this has already doubled. So it's at 105,000 in 2023. Something correspondingly that we're also seeing is a dramatic rise in the overdose death rate associated with stimulants. So this includes the drug categories of cocaine and methamphetamine. And what we're also seeing is that this is driving a large part of the overdose crisis as well, and something that we don't really speak to as much. So as you can see here in figure 6, the number of fatal overdoses involving stimulants back in 2015 was down at 12,000 deaths. This is up to 60,000 deaths, or about 60% here in 2023. So when we talk about this as a opioid or fentanyl overdose crisis, it's a polysubstance use crisis is the way that I like to think about it. And the same pattern is also what we're seeing here in Vermont. And so this figure depicts what you can really see as a steady rise in the number of opioid involved. So this is opioid-related overdose deaths involving cocaine. Kind of weird conceptualization, but think about it as the number of opioid overdoses, how many of those involve cocaine? What you can see is this is now up to 70% in 2024, and it's one of those like year after year after year. You keep seeing it go up, keep seeing it go up. When we had this data from 2021, we're like, okay, it went up, and then it went up, and now we're at 70%. And something that's important to note here is that this is proportional. So when we're talking about it in the scope more generally, or absolute numbers of just the sheer number of overdose happening each year, in 2024, this is much higher. So thinking about it, for example, in 2015, what this equated to at 11% was that 8 out of 73 deaths involved cocaine. And now in 2024, this is 29 out of 183 deaths. So lots more individuals being affected, lots more lives lost. And just depicted here are some data that are more general and highlighting really the role of cocaine involvement in fatal overdoses. And so what you can see here together is collectively as a drug class, so cocaine is the second highest there in the showing up a little bit gold, and then methamphetamine. Together as a drug class, they're actually involved in more fatal overdoses than fentanyl was last year. And what you can see is this slight decrease in the last couple of years in the number of fatal overdoses involving fentanyl. And we can see with 2025 provisional data, this number is still decreasing. And so I think more generally, if you look at the CDC dashboard, it's somewhere around 80,000 fatal overdoses now. So we are seeing a dip or a decrease after the rapid rise. What we're not seeing, though, is any sort of decrease in the role of cocaine or stimulant involvement more generally. In fact, just something I like to always put in here and highlight is that something that's often under-recognized is that Vermont as a state has the second highest rate of fatal overdoses involving cocaine out of any state in the country. With respect to treatment for, here more generally, when we're talking about treatment for stimulant use disorder, it's different where unlike opioid use disorder, as has been alluded to in earlier conversations in our meeting today, there are no FDA-approved medications for the treatment of stimulant use disorder. There's been several classes, lots of work has gone into identifying pharmacotherapies that could potentially be effective and beneficial. However, what we know is that the most efficacious intervention for treating stimulant use disorder is contingency management. You always want to make sure when you have a definition slide and you have Steve and Maxine in your cohort of who's going to be talking to, make sure we get it right when we're talking about what CM is. So here, just a brief background. So it can be defined as a behavioral intervention that uses a systematic delivery of positive reinforcement for the achievement of various goal behaviors. So when we're thinking about this in the treatment of stimulant use disorder, often this relates to tangible items, things like gift cards or vouchers that can be earned for the submission of a stimulant-negative urine drug specimen, or for the completion of other goal behaviors like therapy attendance. So depicted here, and you can actually see it pretty well, so that's good, are the number of states with strategies for funding. So these are statewide initiatives that are either currently underway or in some sort of development for contingency management. And the star there is just my caveat that this is like a really emerging list that keeps growing, and you keep hearing new sources of someone that's doing something or an initiative that's getting started. So it may not be exhaustive, and I apologize if there's any that's been missed. And it is just kept at the state level. If we go into like the counties or individual providers that are talking about that are doing CM, this list would look even greater. And something that's pretty interesting is that if we were to have put this map up in, say, 2020 or any year prior, it would have been blank. There would have been nothing shaded in, minus the Department of Veterans Affairs initiative. And so something, at least to me, that's really cool is that in just a very short time, we're seeing this rapidly shading in and contingency management starting to be available in more and more places. So California was the first state to use a Medicaid 1115 waiver as a source of funding for CM. And so this was a really pioneering initiative that individuals started being recruited in 2023, and it is still ongoing. And other states as well. So Washington, Montana have 1115 waivers. And then there are other states with waivers that are either under review or in development. So I think Hawaii is set to begin pretty soon. Delaware has an 1115 waiver. And then another big source of funding for CM now is opioid settlement funds. And so highlighting this role of polysubstance use, advocating for the use of opioid settlement funds to also be used to fund contingency management for stimulant use is an effective form of that money being used to help address the overdose crisis. And so Vermont, I can speak to and say that they really led the way. So they were the first state to use opioid settlement funds for funding contingency management, which was really great. Other states have moved along as well. So states like Michigan, Connecticut's got a program by previous Sheila Alessio that will be running that one. And then we have some states like Maine that are using a combination of different sources of funding. And so, when we think about what's the ultimate goal here, it's that every state listed on here would be filled in and at some point sooner rather than later. So we're getting there. That said, something that is ongoing in each of the statewide rollouts to date is that implementation is occurring in what we can think of as traditional substance use treatment provider settings. So most commonly, this is in settings like intensive outpatient or outpatient. There's a couple OTPs or opioid treatment programs that are doing it, but not nearly as many. And something else is, to our knowledge, no current projects are providing funding to be implemented in more community-based types of settings, like harm reduction settings, for example. And so something when we're thinking about trying to further expand the reach of the service availability, future efforts could really be looking into expanding CM to more types of community settings like low barrier settings. And this really has the potential to help provide evidence-based stimulant use treatment for individuals that may not necessarily be connected to other types of treatment and recovery supports, or they might not be interested in receiving treatment in some of these more traditional treatment settings where they may have had past experiences, other situations as to why they might not. And so syringe service programs, or I'll be referring to this as SSPs for short, are another potentially promising setting to provide contingency management and really other evidence-based treatments for, and in such a way, in part with syringe service programs, one of the places that they really succeed is that the non-judgmental services are really well liked. People feel comfortable there. The stigma doesn't come along with it as often. And so we've seen with low barrier MOUD that it can be successfully integrated into these sorts of settings. So in the latest National Syringe Exchange Health Survey, I think it was about a third or so, about 33% of programs are now offering low barrier MOUD. So one of the questions that I came into a few years ago that I became really interested in is, well, what does that mean for stimulant use disorder? Could we be offering parallel gold standard in the form of contingency management for stimulant use in these settings as well? And so the studies that I'll be discussing next are part of an ongoing research collaboration that we have with a local longstanding syringe service program here in downtown Burlington. They're like just a couple blocks that way. So right down the road on Clark Street. And I've had the opportunity to work with them for the last few years. And really, I think of them more as, it's listed as a syringe service program, but they're really more of a harm reduction program in the sense of the services and supports that they provide. So it does include sterile syringes, but it also includes pieces like adulterant test strips, overdose reversal kits, low barrier BUP, case management, legal services. Those are just a couple of examples. So in this work, one of the things that we wanted to start with learning more about was current substance use patterns and who are the individuals that are coming in and receiving services, which this is a group that often gets mischaracterized, isn't picked up on other sorts of reporting. So just wanted to learn more about who was actually coming in and receiving services and what was going on. So what we did as part of a larger interview was had participants complete the Washington State Syringe Exchange Health Survey, which Washington State has a really robust harm reduction set of services. So this is the survey that's provided annually to providers out there. And they were gracious to allow us to use it. And so these data that were collected here were lots of different components of things like demographics, housing status, their substance use, injection and health information, and overdose information, and then some information about current or past year treatment. So the sample that I'll be talking about included 150 individuals who were participating in syringe service program services. And what we found were that the results indicated that most participants reported either being unhoused or in unstable housing. About 64% of individuals were unemployed, and then about 20% were on disability. As it relates to substance use, the drug with the greatest proportion of participants that said they were reporting recent use of was crack cocaine, which aligns with what we know about Vermont more generally in the Northeast, where cocaine is the predominant stimulant still, where that differs quite a bit, across the country on where you're at. Methamphetamine out west has been and continues to be much more predominant. The Northeast has just got a hold with cocaine and crack cocaine still, though. What we also found was that about 70% of individuals reported fentanyl use. And this last data point, or these last couple data points here, speak actually really to the success of the hub and spoke model and getting MOUD out there. About 58% of individuals indicated that they were currently receiving MOUD treatment. If you look at that number to a year, it's 77%. So some of the key takeaway findings from this were that there really were high rates of stimulant use being reported across all participants. And the finding here is that this was whether or not stimulants were someone's primary drug, there was high rates of stimulants being used. And this was a bit converse or the inverse of what we found for opioids as a primary drug. So opioid and xylazine use was less common among those whose primary drug was a stimulant than those whose primary drug did include opioids. So it's, the takeaway is all individuals were using stimulants, but the individuals that were the group for whom stimulants were primary weren't also dabbling with the use of opioids nearly as much. And so along with this better understanding of substance use, something that we were also interested in was what were participants' interest in treatment and treatment to reduce or stop their stimulant use. And we also wanted to talk, we're at the University of Vermont, so we wanted to ask a little bit about contingency management as well. And so the two questions that were asked here about interest in reducing or stopping use were very basic. How interested are you in reducing? And then how interested are you in stopping your use? So there were 4 response options, either very, somewhat, not sure, or not interested. So I'm not sure if we have our pointer here still. So on the x-axis in these figures here, so these are the results. And on the x-axis, we have the percent of participants and then the group shading. So very, somewhat, not sure, not interested. And then on the y-axis, we have, so at the top, it's all participants. And then this is broken down by primary drug type. So there were 3 primary subgroups, those for whom stimulants were their primary drug, those for whom opioids were their primary drug. And then there was a group of individuals that for both stimulants and opioids, they considered their primary drug. What we found was that overall, about 60% of individuals reported interest in reducing or stopping their use, with this interest slightly higher among individuals in that stimulant subgroup. And then so along with this, participants were also asked what types of services might be of interest if they were easy to get or obtain. And so the response options here included pieces that you'd think, so inpatient, outpatient, detox, help navigating service supports, financial incentives for non-use. And then we also asked about medication that may help reduce your stimulant use, mental health medications, or I'm not buying what you're selling, I'm not really interested right now in anything. And so what we found with types of help of interest was, by and large, the interest was highest for, kind of might guess, incentives. If asked and money's part of that, then that was the highest of interest. Not surprising to us. What we also found, so on the far right-hand side, was that about a quarter of individuals indicated they weren't interested in any types of help or support. So that's just something important to note. And then one other piece that was interesting with these data was that not many individuals indicated that they were interested in medication to help reduce their use. And just an anecdotal piece of information is that a good chunk of people have a prescription stimulant, have been prescribed stimulants, and that's included here as well. So a lot of people with stimulant use disorder also have that component too. And then we asked about interest in CM. So we had participants complete a brief interest in CM questionnaire. And so here what we were looking at were a few different pieces. So how interested would you be in CM to reduce or stop your stimulant use? What about interest when you frame it a little bit differently? So if you could potentially earn $1,200 over 12 weeks, and you'll see why that number was used in just a couple minutes. And then some of the logistics. So like, is it possible, or would you be interested in coming in twice per week for CM visits? What about once per week? And then one of the questions that I wanted to include was, if you're thinking about your use, if you were to try contingency management, what would be your hope? Would you be wanting to reduce your use or completely stop that use? And so what we found regarding interest was about 83% of individuals reported that they were interested in trying CM to reduce or stop their use. And that goes up slightly if you ask it in such a way that the money becomes a little more salient. So about 92% said that they'd be interested if they could earn $1,200 over 12 weeks. And then 84% or right about there said that they would be likely to come into the SSP a couple times per week for CM visits. And if you've ever done any work in a syringe service program, a lot of individuals are like, I'm here every day, or I'm here all the time. Like coming in twice per week wasn't going to be a barrier to participating in a program. And then when asked about the goal to reduce or stop that use, about 2/3 of individuals indicated that their goal would be to completely stop their use as opposed to reducing their use. So taken together, what these data provided were some insight into substance use patterns and then into potential interest in treatment services among this population. And importantly, part of this question stemmed from wanting to obtain some more quantitative data and information that would be able to be talked about as a way to sort of help describe a lot of the anecdotal information that had been reported to us from both service recipients and staff. And that many individuals were interested in treatment, they just weren't sure where to receive those services, or they weren't interested in traditional settings. So what this really did was provide some insight into that, and then led to our next step, which was a project to conduct a randomized controlled trial to examine CM for stimulant use in this setting. So this was a parallel group randomized control trial where there were two study conditions. The first study condition was a health education condition in which participants could earn incentives for attending that session visit and providing a urine drug test. And then for the CM group, I'll talk about both in a little more detail. But generally with the CM group, it was for stimulant non-use, and participants could earn incentives for providing a urine drug test that indicated recent stimulant non-use. And so the study duration was 12 weeks with twice weekly visits. So more specifically with the protocol for the CM group, the incentive value for the first stimulant negative urine drug test that was provided would be $25. And then there was the escalation component. So there was a $2.50 increase for each subsequent consecutive negative urine drug test provided. The max per test that could be earned was $65. And then there was also the reset component where if someone had a stimulant positive test or missed a visit, then it would be reset back down to that base level. So overall, across the 12-week period, it was about $1,200 to $1,220 that someone could earn if they provided a negative test each time. And then in the health education group, someone could earn about $240, so $10 for attending each visit, and that was not contingent on those test results. So our primary outcome was the percent of stimulant negative urine drug test results, and we used an intent to treat approach. So all individuals that were assigned to a study condition were included in the analysis, and all missed visits were coded as an assumed stimulant positive result. So in total, this study included 27 participants, so 14 in the CM group, and then 13 in the health education condition. So depicted on the left-hand side here are the aggregate results for the percent of stimulant negative urine drug tests provided by condition. And 23.7% of all potential UDTs were stimulant negative in the CM group. And this compared to 6% in the health education group. So what we found was about a fourfold difference in that the difference in the number of urine drug tests provided that were stimulant negative. And this equated to an odds ratio with GE using at a 4.8. Then on the right-hand side, what we have is another measure. So the longest duration of continuous stimulant non-use. And so what we found was in the CM condition, 4 individuals demonstrated non-use of at least 4 weeks continuously. And then at 8 weeks, 3 individuals met that. And just as a comparator in the health education group, there were no individuals that met either of those non-use durations. And then what I've added here is session attendance on the right-hand side. So what you can see is that comparatively, session attendance was greater in the health education group. So 62% versus 33% of session visits attended compared between the two groups. So overall, these preliminary findings do have a couple takeaways for us and some implications for future research. And one was that this is a pilot study to indicate that CM can reduce stimulant use among syringe service program service recipients, which sometimes is thought of as a setting or a place in which it's often mislabeled or characterized as not necessarily interested in treatment. They're there just for the other harm reduction services. And that what we found was that wasn't necessarily the case. Additionally, what we did see that while the percentage of stimulant negative urine drug test results that were found in the CM group and the health education group, they're somewhat lower than what you find in the extant literature more generally around CM. But we did see this fourfold increase in the percent of stimulant negative urine drug tests in the CM group. Additionally, kind of as you might have expected, we saw better session attendance when those incentives were included for attending the visits and not included or not contingent on the UDT results. And then finally, this study was the first to our knowledge to examine CM in a syringe service program type setting and with this population, indicating that it was potentially feasible, and it provides another potential novel community-based setting in which to add this in the continuum of where CM could be provided when we're talking about implementation more generally. And then we now have a CM certificate course. So if you know anyone interested, there's a link for that there. Thanks.
Thanks. Okay, thanks, Tyler. And again, we're holding questions until the end of the session. A man who really doesn't need any introduction, but I will go through it anyway. Steve Higgins, who's the director of the Vermont Center on Behavior and Health, a university distinguished professor, and the Virginia Donaldson Professor in Translational Science in Departments of Psychiatry and Psychological Science here at University of Vermont. And he's going to be talking about improving smoking cessation interventions with perinatal women.
Thank you, Sarah. I want to, the title is shown there, Advancing Women and Infant Health by Addressing Rural Disparities in Cigarette Smoking. So this is a topic that I've been interested in for a handful of years now. So I have nothing to disclose other than NIH grant support. So U.S. rural health disparities have been a concern since the 1980s. And rural communities have a greater prevalence of risky health behaviors across the board and worse outcomes than urban regions. Back when the landmark 1964 Surgeon General's report on smoking and cancer was released, smoking prevalence was actually lower in rural communities than urban regions for both men and women. And while smoking has decreased considerably since that time in both rural and urban communities, a disparity has emerged. And so my overarching aim here is to provide a brief overview of the disparities focused on U.S. women of reproductive age, especially the pregnant ones. They're the ones I'm most interested in because of the potential for multi-generational adverse effects, and then share an evidence-based smoking cessation treatment that we've developed for perinatal smoking cessation with the potential to reach rural women or people living in geographically remote areas. It could be an urban area where people don't want to go out of the house, but largely we're focused on something that can reach the rural women. So in 2024, in preventive medicine, one of the special issues associated with this conference, I reported this study along with Tyler Erath and Fangfang Chen, looking at disparities in smoking among rural versus urban women of reproductive age across this period of 2002 to 2019. We used the National Survey on Drug Use and Health, which is a nationally representative survey of U.S. civilians, non-institutionalized population age 12 and above. And we're comparing current smoking status defined as you used in the past 30 days and you've used at least 100 or more cigarettes lifetime. And the reproductive age range we used was 18 to 44. And residing in rural versus urban areas using criteria that are commonly used in this type of research. And then we adjusted for race, ethnicity, education, income. And emboldened the education and income because of this is a topic that those are factors that increase smoking during pregnancy. And in 2009, we did a special issue of drug and alcohol dependence on the relationship between those factors and smoking in women. We also looked at, in addition to prevalence, we looked at quit ratios. Just as a reminder, that's the proportion of those who endorse lifetime smoking but report no smoking in the past year. So former smokers. And we're looking at our data in 2-year bins. So on the left-hand panel there, I don't see a pointer, but oh yes, I do see a pointer. In the left-hand panel here, we're looking at prevalence rates. The red bars are rural women, the blue urban women, and we're looking across time. And what you can see is there is disparity already in 2002 with more smoking in the rural women, but the disparity is actually growing over time. So this is a reason for concern, I feel. And so then these are the not pregnant women over here, and the pregnant women, you see that same disparity. And the only reason you're seeing more variability is the numbers of pregnant women are much lower than over here. And yeah, so you get a little more variability. Well, then in the quit ratios, it flips. So you want to be higher rather than lower. So if you look at the non-pregnant women, there's more former smokers in the urban areas than the rural areas. And again, you see that the difference is growing over time. And the difference is also evident in women who are currently pregnant. All right. So more recently, just for the special issue that's not even out yet, we have an article where we wanted to look at this disparity by chronological age among women to see who is being most impacted. And so we are doing the same thing I just described, but we're going out to 2021 and 2022, so a little further out in time. And we're looking at chronological age. So if you look over here, the data are collapsed across age. And this is pretty much like the other figures I was just showing you. Rural women up here, urban women there. So it's just taking that plot on prevalence out a little further in time. And again, it's continuing to grow over time. Then when you look at chronological age, we're collapsing across years now and just have the women organize in these age bins here. And not only we learned, and I didn't know this going into the study, but not only is the disparity impacting women of reproductive age, they're the ones who are shouldering the burden. That's where the burden is greatest. And so you see a little bit of 50 to 54. I don't even remember if that was statistically significant. These age groups were highly significant. And then the 65 plus group is another story. It's an interesting group, but there's no rural urban disparity there. All right, so the disparity is robust. It's disproportionately impacting women of reproductive age, likely contributing to observed rural disparities. If you look, you could just Google, or the prevalence, or is there a rural disparities in SGA, small for gestational age delivery? And you will find that there is. And so you pick any smoking related outcome and just ask, is there a difference between rural and urban communities? And ask it about women, and you will find that there is. And this one, I think, is particularly concerning. This is sudden unexpected infant death. So as parent or grandparent, it's a horrific outcome. And it's directly associated with smoking during pregnancy or smoking while parenting young children. But yeah, not much is being done about it. So these differences that I'm showing you, they can't be completely accounted for by differences in socio-demographic or socioeconomic disparities. I mean, those factors, that's why I'm noted, we knew since 2009, they're big contributors, no doubt about it. But if you control for them, you still see this rural disparity. And we think it has to do with disparities in accessing evidence-based smoking cessation interventions and also enforcement of tobacco regulatory regulations, and likely that they're both likely contributors to the disparity. And you might know, like, rural hospitals are cutting or closing, or services in rural communities are decreasing just because of the issues you're seeing in the news. All right, so we're committed to improving smoking cessation interventions for perinatal women. So smoking is the leading preventable cause of poor pregnancy outcomes in the U.S. and other developed countries. I've mentioned multiple times already that rural and SES disadvantaged women are at increased risk. The interventions, like if you asked Department of Health or other people, there are efficacious cessation interventions widely available, but the problem is that the cessation rates achieved with them are really low. So about 10%, and I'll show you that in experiments. Usual care is typically a referral to a quit line. Best practices includes following up on that referral if women are continuing to smoke to make further referrals. And then financial incentives, we believe, represents an innovation. And you heard at the New Time, Jamie was talking about that at the level of meta-analysis that can reliably increase quit rates. And I'm going to show you improved birth outcomes. All right, so this is a paper that we reported in 2022, and you could see I had multiple co-authors. This is always team science. So what we did here, we're comparing best practices, I just defined that for you, or best practices plus financial incentives. We take 169 women who were still smoking at their first antepartum visit, which is usually around, in Vermont, about 11 to 12 weeks gestational age. And then we also included 80 SES matched, socioeconomically matched to the women who smoke, but these were never smokers. And we did that around birth outcomes because we wanted to see, okay, can you improve birth outcomes by getting women to quit? But how close do you get them to never smokers? I'll show you. You can't eliminate the difference. So, but I'll show you that. Secondary outcomes, birth outcomes. I already mentioned small for gestational age, defined as less than the 10th percentile for gestational age, and cost-benefit analysis. And then we also threw in here, we had done multiple trials. So just to get the ends, larger ends on some of the outcomes of interest, we also included a data set that collapsed across prior trials that randomized trials we had conducted, where women either received an intervention that included financial incentives or a control intervention that did not. And so we're just going to organize them by that. So we have 245 women who received an incentives intervention and 208 who received some form of control intervention. And then we also include an external validity. So working in collaboration with the Vermont Department of Health, we looked at all births in Vermont in 2019, which was the last year of the clinical trial. And we wanted to look at this small for gestational age outcome by maternal smoking status, which we could get off of the birth records. So, all right, the incentives models is familiar to many of you, and Tyler was just talking about, but vouchers exchangeable for retail items. They were available antepartum through 12 weeks postpartum. So about 36 weeks intervention. Vouchers are provided contingent on biochemically verified test results showing abstinence. We do these periodic absence assessments conducted through 12 weeks postpartum in the incentives group. And then the voucher value starts relatively low and it escalates at each consecutive negative test up to a maximum of $45. And then a positive test result will reset the voucher value back to a low level from which women can regain the higher value incentive with a couple instances of negative urines. So overall, what we paid out for the results I'm going to show you in the incentive group is about an average of $510 over 36 weeks. So that's not really a lot of money looked at over 36 weeks. All right, so data. I'm going to show you the current trial results, best practices in the red bar, the best practices plus financial incentives in the blue bar, and the antepartum period. We have an early antepartum assessment, and then a late pregnancy. And when you're trying to protect the fetus, this is the key outcome and our primary outcome. So with the incentives, we have 38% of the women biochemically verified abstinent versus 9% in the control condition. So like a fourfold difference in late pregnancy abstinence levels. You get a little bump in the control condition in the early postpartum. Most women don't smoke when they're in the hospital delivering. So you get a little bump here. Both groups, as you get further away from delivery, the abstinence levels are decreasing, but remaining significant as long as the incentives are involved out through 12 weeks postpartum. 24 weeks postpartum and 48 weeks postpartum, you still see a little greater absence in the incentivized group, but in this sample size, they're not statistically significant. If you look down, so this is why we're interested in having pooled results to get larger samples. If you look down in the pooled results, the pooled trial results, the outcomes in the antepartum period are really similar to what you see in this trial. So it's a highly reliable effect, as is sustaining the abstinence through the 12-week postpartum period. This trial up here is the only time we went out to 48 weeks, so we couldn't represent that in the pool data, but at 24 weeks, it's statistically significant. So the effect that you saw during the incentive period is sustained at least out through 12 weeks after the incentive program is discontinued. All right, so now small for gestational age deliveries. So I have them, the colors the same. The red bars are the people who just got best practice, the infants born to people who just got best practices, blue, women who got the incentives, and then never smokers. And then these two columns here is just in this area of research. There's some debate. Should you look at all infants? Should you look at term infants? The experts suggest term infants. And you can see it's a little crisper difference here, but it didn't really matter too much. What you're seeing is this graded effect where the highest rate of small for gestational age deliveries is in the women treated without incentives. And by providing the incentives, you could cut that by about half. And then, but you can't get them back to never smoker level, which kind of makes sense, you know, because some of the women in this condition didn't quit. But anyhow, getting people back to as though they were never smokers doesn't seem doable, at least in the way that we treat them. And then in the pool trials, again, very, very similar to what you were seeing here. So a highly reliable effect. And then I like this part. This is the let's go out and free ranging, if you will. I don't know, but I had never done a study like this. So this is all infants born in 2019 in Vermont. And then by the based on the delivery record, these are women who reported smoking throughout the pregnancy, small for gestational age deliveries to women who reported smoking throughout the pregnancy. The blue bar is women who said they were smoking during the current pregnancy, but they had quit before this third trimester, which is the trimester where the greatest growth occurs. And then these are the never smokers. And the function is about identical to what you saw in the experiment. So it's a very valid, externally valid observation, this effect of smoking cessation on small for gestational age delivery. There's nothing, another way you could say, there's nothing magic about getting the women to quit with incentives. It's if you can get women to quit, you will get this relationship. And this was just broken down by different types of insurance. And you see the same relationship independent at the largest group who smoked during pregnancy or Medicaid insured women who are the more disadvantaged group. All right, so then we did an economic analysis led by Don Shepard who's a health economist from Brandeis who works with us. And the long and short of it is for the current trial that I showed you, it was a $4 return for every $1 invested in the incentives intervention. And then in the pool trials where you get, I think, a better estimate, it increased to $12 return for every $1 invested. And that's consistent with what you heard in Jamie's talk, that it's cost effective to do this intervention. All right, so then in an effort to be able to reach women who are in geographically remote areas or don't have access to a hospital, we translated this intervention so you could deliver it with a smartphone. So we never saw the women. So this is Allison Curdy led this trial, and you'll see the other collaborators here. And this is a national sample of women recruited online. And the intervention was essentially the intervention that I just shared with you. And the outcomes here, you have best practices alone, dark bar, light bar, best practices with the financial incentives, the same early pregnancy, late pregnancy, and you can replicate that effect without ever seeing a woman, just doing it through a smartphone. And Allison was smart enough to look in the literature, like what proportion of economically disadvantaged women have a smartphone or access to a smartphone. It was like 80 or 85%. So that's not a problem. All right, so in Lunch and Learn, we heard from Jamie Hartman-Boyce here, and she went over the incentives for smoking cessation. And I actually forgot my seat and lunch. I remembered about midway through and raced up, but I don't know if she showed these forest plots, but if she did, yeah, I apologize for showing them again. But this is the forest plot from that Cochrane review on the late pregnancy or end of pregnancy absence effects and meta-analyses, trials that we did, but trials that other people have done. And you get this, clear improvement in late pregnancy absence by including financial incentives. And, everything's on the right side of this bar. So it's an effect that's pretty darn reliable across trials. And then this is the latest, the furthest out the assessment was done across studies. And so you get a somewhat smaller effect size, but it's still highly significant. All right, so in 2025, SAMHSA put out this advisory on contingency management for substance use disorders. And they said that you could use finally federal funds to support contingency management, but they capped it at $750 for any individual in a 1-year period. And then they also said that this should mostly be used with people who have stimulant use disorder or cannabis use disorder. And the rationale there was because those were the two substances for which we had effective point of or place of contact. What's that? Where's Tyler? I always forget what this acronym. Point of care test, biochemical verification of the test of the drug use status. And but it turns out so, and in short, the smoking cessation was not included. Perinatal smoking cessation then, of course, was not included. They cap it at $750, but that's for interventions that are typically 12 weeks in duration. Ours are 36 weeks in duration. So that $750 is really not a great fit. But better something than nothing. So we have a grant in with NIDA to see if this $750 will work for perinatal smoking cessation, or some data from the UK that's suggesting that you will still get better outcomes than you do without the incentives, but the effect sizes are probably going to be smaller. And if you get smaller effect size, probably less likely you'll be able to discern birth improvements in birth outcomes. But we're going to go with it. and it'll be done in collaboration with the FDA. So first, if we could show the 750 works, this is all the smartphone. This is a digital intervention. Some of you may know that that NIDA has this program now for advancing digital treatments for substance use disorders. You work in collaboration with the FDA. And so you do our first study will be whether we can get an effect at that $750 maximal value. If we can, then we do, in collaboration with the FDA, a large effectiveness study. And if that all works out, at the end, you have an FDA-approved digital treatment. And so in the future, if a woman is pregnant when she goes for prenatal care, the obstetrician or primary care doc just writes a prescription and says, here, go see Dr. Henningfield. But, you know, joking aside, that's how it will work. And I think the intent is to have it function like medication. So we're going to be able to deliver the intervention within the medication delivery framework that we have in our medical healthcare system. All right, so just to wrap up then, robust evidence that financial incentives are efficacious and cost-effective for perinatal smoking cessation. We've already mentioned England recently implemented this nationwide. And then we know already, and have talked about it during this conference, that financial incentives are efficacious for other substance use disorders, especially stimulant use disorder. So that's finally moving forward in the United States. Tyler mentioned the rollout in California, and now it's in Vermont and a lot of other places. So that's good. There's sound scientific rationales underpinning the efficacy of financial, and sometimes it's like thought to be lowbrow, like we don't know, but if you dangle a couple dollars, but we do understand why they would work, you know, and you're offering short-term reinforcement. So essentially you're leveraging the same processes that put people at risk for substance use disorders as part of the recovery process. So then lastly, this is kind of a, I don't know, pet peeve, but I think it's an important point. If the U.S. is to reduce health disparities, so now, like if you look at U.S. population health compared to other developed countries, we are horrible. And we're just below every other developed country by a lot. And so now we're doing well with psychomotor stimulants. Our first trial in psychomotor stimulants was 1991. So it's taken about 35 years. Well, I didn't feel too bad when I heard about buprenorphine. And then Dorothy and I were talking about what's happening with nicotine reduction in cigarettes. I think that's just how it is. It takes a long time. So I remain upbeat and excited. Yeah, so we'll see where it goes. Thank you.
Okay, now we have a woman who likely needs no introduction. Our next speaker is going to be Maxine Stitzer, who is Professor Emerita of Psychiatry and Behavioral Science at Johns Hopkins School of Medicine. And she's going to be talking about remote contingency management for alcohol use disorder.
Thank you. Well, I think this is going to dovetail nicely with Steve's talk, because I believe the product I'm talking about is the same one that was used in in his smoking cessation. As Steve actually saw these data at a small oral session at CPDD and asked if they could be repeated here to a different audience. And so I said, sure, but it's been such a privilege and a pleasure to come to this meeting. Oh my gosh. Well, first of all, it lets me reconnect with my behavioral pharmacology roots, which hasn't happened in a while, and to reconnect with old friends and colleagues, and to pay tribute to the latest two fallen giants in our field, Warren Bickel and John Hughes. Sorry, I don't like thinking about these folks that have left us. So I think I pressed this, yes. Right, so I've got some disclosures here because Justin Strickland, who's the co-author, and myself, we both have been consulting with Dynamic Care Health, which is the business group that has developed this remote digital therapy for contingency management. And I have to give a shout out today to Justin because he took the data from this app and, and sorted it out, analyzed it, and made the beautiful graphs that you're going to see today. Now, because this was a look-back meeting about behavioral pharmacology, I decided to put in a few fun slides at the beginning about how this all started. And I think that this guy was responsible. A few of us who went to graduate school in the 60s got real excited about B.F. Skinner and the idea that behavior could actually be a science, or that there could be a science of behavior, using by influencing actions through positive reinforcement of desired behaviors. Then I went to Hopkins in the mid 70s. And George Bigelow and I put our heads together and decided to try to apply contingency management to addiction treatment by conducting some small proof of concept studies. And I've shown some of the principles that we applied, which were a little bit innovative at the time, actually, intervening directly on outcomes, on drug use outcomes, rather than on mediating variables like motivations, intentions, cognitions, and skills. Using objective measures to understand the outcomes, intervening with reward versus punishment, intervening on a single drug. That was kind of a practical decision, I think. It was easier for the patients to understand what their job was, what their goal was, and it's easier to the investigators to understand the outcomes. But it's turned out to be, I think, a good decision, producing interesting data. Identify desirable rewards. That wasn't hard. We used methadone take-homes because we were working with methadone maintenance patients. Also, of course, the universal conditioned reinforcer is money. And enrolling only those exhibiting the problem. Steve made this point about the impulsive kids. In clinical practice, often people want to give the intervention to everyone who walks in the door, but that's not who needs it. It's the people who are using your target drug that need it. So we did small proof of concept studies. In those days, you could test 10 people and write up a study. But we also had a postdoctoral training program that proved to be very influential because we had some people come through our program who became the innovators of new developments in contingency management. Steve devised this sophisticated escalating schedule of voucher reinforcement, which I've always admired so much because the way that it sustains reinforcement over time and bridges the gap before you get to any kind of eventual delayed reinforcers. And then wonderful Nancy Petrie, who trained with Steve and Warren Bickel as well, using intermittent reinforcement with her prize draw method. And finally, Ken Silverman, who developed the therapeutic workplace, allowing people to work and earn salary as a reward for negative urine testing, for abstinence on their drug. The researchers loved contingency management. A whole slew of people took it up and worked with it. I think they liked it because it was a concrete protocol that they could implement, and it always gave them good data. And I already know someone I left out of this list, which is Alan Budney. I forgot to put him in there. Apologies. But these were the people that came to mind when I thought of making this slide. So many researchers working on this issue. Efficacy was clearly demonstrated, usually in protocols that brought patients into the clinic to receive their contingencies in a treatment clinic setting. Stimulants for sure, tobacco for sure, alcohol. I didn't put opiates up just because of the medications or the primary treatment for there. And so we developed an evidence-based practice, or an evidence-based practice emerged from all this work, verified in randomized trials, analyzed in meta-analyses, and recommended in treatment guidelines. But we all wondered whether it was going to just be a footnote in history because clinicians didn't use it much. There were reasons: lack of workforce knowledge and training, and some philosophical issues, complexity, difficulty integrating it with the workflow of a clinic, and then the eternal question, where's the money to pay for this, which is still a question. However, as we've seen, and I won't dwell on this because everyone has brought this up, there's a renewed resurgence of interest in contingency management. And I think it's due to two things. Just this is speculation, but one is advocacy, which is so important in every development. People like Rick Rawson and Michael McDonald, and yes, David Gastfriend, are out there beating the bushes and talking to health departments and insurance companies and trying to interest them. And many states have now come on board with interest in this protocol. But another development that's helped is the technology for offsite delivery, such as what Steve was beginning to allude to in his talk. We've had the drug testing equipment for quite a long time: breathalyzers, CO monitors, saliva kits. But now we have some new developments in digital therapies that can support remote delivery of contingency management. So this is the particular digital therapy that I'm going to talk about. It's the Dynamic Care Health phone app. It works from a smartphone. And the way it works is this. Well, the patient has a smartphone or is given one. They're also given testing equipment, breathalyzers for alcohol, saliva test kits for all the other drugs. It has a 10 drug panel, the saliva kit. And they're able to test themselves offsite in their natural environment. Texts are sent to the patient requesting testing, requesting either an alcohol or drug test. And one of the cool things about remote delivery is that this testing window can be expanded way beyond what can happen in a brick and mortar clinic, because you can do it in the evenings and on weekends. So you've got a much broader and more flexible window for drug testing. So the patient tests themselves while they're videotaping themselves doing the test. They videotape themselves, they videotape the results of the test, and they send it off through their phone to the dynamic care staff. And I'm sure one of these days AI is going to take over this part of the function, but the staff, these human people, have to validate the test, make sure it's the right person and the correct results. And if the test qualifies for reward, then the staff can deposit money directly on a personal debit card, which is another little advance in technology that's allowing immediate reinforcement. So cool. So these are some of the features of the Dynamic Care phone app program. The abstinence incentives are a central feature of the intervention. 70% of available reward amounts are allocated to the substance test results, and in this case, it's $20 out of $30 per week that can be earned. There are some other treatment components included. It's a multifaceted intervention that you need to know about. They've got CBT self-learning modules in there that the patients can access. This is very common in all the digital therapies. There's an appointment scheduling and tracking feature, and there's also abstinence coaches is available by video, phone, and texting, which is an interesting feature that we can talk about afterwards. So these folks applied for an SBIR grant, and that's what I was consulting on. And this is a study done with alcoholics. So we're looking now at alcohol as the target drug. 221 participants were randomized. They were recruited both from treatment programs and from Facebook advertising. Participants had to meet criteria for AUD, alcohol use disorder, and have recent alcohol use reported before they were randomized in the study. You can see the mean age was early 40s, about a 50-50 split on male-female, which is nice, primarily Caucasian, which could be improved in future studies. About a 60-40 breakdown between rural versus urban, and it's interesting to know that many of the rural participants came from Vermont, yeah. And then about a quarter of them were also using illicit drugs in addition to their alcohol, which of course is a common clinical scenario. Marijuana, by the way, was not counted as an illicit drug. So here are the randomized study methods. The intervention group could earn up to $960 over 32 weeks. So that's a nice long intervention, 32 weeks. This is $30 per week with randomly scheduled testing alcohol 3 to 4 times a week, drugs 1 to 2 times a week, $10 rewarded for negative alcohol and $10 for negative drug test. An additional $10 was available for module completion and this appointment keeping business. The design included a non-contingent control who were paid. They had a phone, they had the app, and they were paid for sample submission only, irrespective of the results of the test. They could earn $640 over 32 weeks. And then during a 20-week follow-up, after the intervention ended, everybody earned the same amount of money for submitting samples. So now we can get into the data and some of Justin's beautiful graphs. This is the engagement data using the definition of at least one alcohol sample submitted in a given month. So it's a pretty low bar. Using this definition, you see we had about 70% retention at the end of treatment, at the end of the 6 months, and about 50% at the end of the follow-up. But the main point here is that the two groups look almost identical. So similar amounts of data were collected from the two groups using the non-contingent control condition. Also, and just putting another fine point on that, the two groups earned similar amounts of the total possible earnings, about 50%, which is typical for a CM study. This is the primary efficacy outcome measure, so this is really important. The primary outcome was at least one confirmatory negative breath alcohol test within a given week. We're now talking about weeks. No positive tests submitted and no self-report of alcohol use. And of course, they had surveys that they filled out as well as an online survey. So that's the definition of a negative alcohol week, or a week without alcohol. And here's the primary outcome data. This is the percent who meet the criteria for alcohol abstinence in a given week over the 32-week trial. Intervention in blue, control in yellow. And of course, you can see that the intervention group did significantly better than the control group, a higher percentage meeting alcohol abstinence, with an odds ratio in the data analysis of 4. So that's a very pleasing outcome for a contingency management study. We took a look at some modulated, I'm sorry, this is the individual outcomes data, longest number of successive weeks without alcohol detected. So this is like the longest duration of abstinence measure that's been traditionally used in the field. And here you see a significant difference again between the groups, about 10 weeks of continuous abstinence for the intervention versus 4 weeks for the control. So pretty typical, satisfying CM outcome data. Oh, this is good. Slightly different measure. The self-reports are not included here, just the alcohol test. But what you see is that there was an effect of the intervention continuing after the intervention ended at 32 weeks. Always a gratifying thing to see. We took a look at some of the modulating variables, gender, geography, and illicit drug use. And what I'm going to show is the data for the longest successive weeks without alcohol, the continuous abstinence measure. So here's gender, males versus females, and you can see right off just by the colored bars that there was an effect of the intervention in both males and females. And you see the effect sizes up at the top there of the bars. So the effect sizes were virtually identical. So no interaction with gender, both males and females benefited equally from the intervention. Here's rurality. Did you live in an urban or a non-urban setting? You remember about 40%, 60%, 40% breakdown of the sample. And again, you see both urban and rural had effect of the intervention with, again, similar effect sizes. If anything, the rural people did a little bit better, but that I don't think would be a significant, I'm sure it wouldn't be significant, in fact. So generality there. And here's illicit substance use. 25% using illicit substances, marijuana not included. And again, you see an effect in both those who did and did not use illicit substances. But here, and this hasn't been analyzed, but there's a chance that the people who did not use illicit substances did better overall than those who did. Well, that makes sense clinically anyhow. So it would not be surprising if that were significant. But the point is that both groups benefited from the intervention. So generality has been demonstrated across three important variables: gender, rural versus urban dwellers, and AUD with and without illicit substance use. I'm sure you're curious about what happened with the illicit substance use, because after all, the contingency included monetary payment for negative drug tests as well as for negative alcohol, right? And here you see the intervention effect on illicit drug use. This has nothing to do with alcohol. This is just the saliva tests for illicit drugs. And once again, we see a significant effect of the intervention. This is the full sample. So the percentage of people meeting drug abstinence with negative tests is fairly high because only a quarter of the people actually used the illicit drugs. But you see a significant effect of the intervention with an odds ratio of 3. What's not to like? So I think that I can draw my conclusions here. Remote delivery of contingency management abstinence incentives is clearly feasible using, at least with this particular intervention strategies, remote self-testing, staff validation, and direct deposit of monetary rewards. Efficacy was demonstrated for alcohol use disorder in a well-designed study that used non-contingent, that paid the control group in order to balance data collection. Always important, that try to have equal amounts of missing data in the two groups. Generality demonstrated across multiple patient subgroups. With a point, I think the same point that Steve made is that efficacy shown for rural substance users is noteworthy, since remote delivery of contingency management could address a critical treatment access barrier. And I want to throw up one more discussion point, because it occurs to me that these kind of digital therapies that are easier to use because they take the clinician out of the workflow, and so they're going to be appreciated, I think, by the field in general. But also, I think that's a really great opportunity to do parametric research, because it's going to be a lot easier to do that with a remote delivery where you can modulate the program in order to vary your parameters. So I think this could be a good way, and have access to larger samples, not have to rely on recruiting from clinical programs. So I think that that's another discussion point. And thank you very much for your attention.
Now we have the final speaker in the final session this year, Diane Galima, another VCBH training program graduate, was a faculty member at UVM for a number of years and is now the Associate Director of Research and Associate Professor in the Department of Cardiovascular Medicine and Internal Medicine at University of Texas Medical Branch. And she's going to be talking to us about contingency management to improve health outcomes in those with cardiovascular disease.
All right. I am impressed that there are still so many people here at the very last talk of the very last day. So thank you all for sticking around. And I will mention, about the redheaded stepchild part that someone else mentioned earlier. I am not talking about substances at all. So I feel like I'm even more like, where am I? But it's always an honor to be able to come and talk at this conference. So thank you, Steve, for inviting me back. And I'm happy to come here and keep talking about cardiac stuff. All right, so here's my disclosures. I have no conflicts. Stuff I'll talk about was funded by various ways, but I have no conflicts. So, as I cry here. So as Steve mentioned, we lost one other member of VCBH last year, and so that was Pilatus. And he was a huge part of my life for over a decade. And so this talk is my way of giving tribute to the work that he's done. And anyone that knows Phil knows that he was a huge proponent of cardiac rehab. And not just that, but he was like a visionary leader in the field. And the cardiac rehab program here is world-class and science-based, and it's all because of Phil. And so just take a moment to appreciate him. All right, so now I gotta tell you what cardiac rehab is, because I'm not in my usual cardiac rehab conference, so here you go. So what is cardiac rehab? So this is a medically supervised, structured secondary prevention program. So anyone that's had a cardiac event, so they had an MI, they had bypass surgery, they had valve surgery, they had a PCI or stent. The kind of gold standard treatment after that is that you go into cardiac rehab following that event. And so most of the cardiac rehab that we do in the US is what we call phase 2. And this is an outpatient therapy where people go to an outpatient clinic and they engage in these sessions. For up to 36 of them are reimbursed by most insurances here. But you go, you do structured progressive exercise in a monitor environment, and then you get a lot of guidance about medication adherence, controlling your symptoms, changing your diet, smoking cessation, all the things that you need to do to be able to prevent yourself from having an additional cardiac event. And so I will mention that one of the focuses of cardiac rehab is really on improving cardiorespiratory fitness. So getting your lungs and heart back into shape. And that is mainly because that is one of the biggest predictors if someone is going to go on to have another MI or end up in the hospital or die prematurely. All right, so cardiac rehab, we all love cardiac rehab, anyone who knows anything about it, because we know that people that attend cardiac rehab have significant reductions in morbidity and mortality. So there's a lot of meta-analyses out there that have looked at randomized trials. There were a lot of randomized trials that were done before it became standard of care. And we see these significant decreases in cardiac mortality, cardiac rehospitalizations, you get improvements in return to work and quality of life. And that it's really interesting because you can see these benefits in the people that attended cardiac rehab even 5-10 years after they attended the program, their health benefits maintain. Unfortunately, we don't see the kind of attendance rates we would like. We have all these great preventative programs, and what's the issue is people don't use them, or at least not at the rates that we'd like them to. So we know that for people that are eligible for cardiac rehab. Less than half of those that are eligible in the US and Canada participate. Dropout's also a problem. You got these 36 sessions. That's a long time to expect people to go 2 or 3 times a week for 36 sessions. And so people do drop out. But when people look at the benefits of cardiac rehab, you see this dose-dependent relationship. So we really want people to attend as many sessions as they can. And then when we look at, there are course predictors of the people that do not attend cardiac rehab and then drop out prematurely, and being lower SES is one of those big predictors. All right, so of course, then the big question is, how do we improve cardiac rehab attendance? And obviously, since I'm here talking about contingency management, I will be talking about contingency management. But first, I'm going to take a little detour and talk about something else. And that, since we're talking about behavioral economics and behavioral pharmacology, we're talking a little bit about the behavioral economics of cardiac rehab. So before getting involved in the whole cardiac rehab field, I had no idea about how much people in healthcare cared about money, but I sure learned. It was one of the big things I learned working with Phil over those years. It's just cost is a huge consideration. And most of the costs that the system cares about are, of course, the system costs. So they're very interested in what does it cost to deliver this care? What is the reimbursement that's available through the various insurances? And what's the potential cost effectiveness of these therapies? So we heard a little bit about cost effectiveness from some of the other talks. I had, once again, never heard of cost effectiveness before entering the healthcare field. But then when we think about behavioral economics, we also need to think about costs on the patient side. So we've got co-pays, cost share. We've got, the cost of getting there, accessing it, and then also the opportunity cost of actually accessing the treatment. So this is something else that I wasn't tuned into until I started working with those patients, is what are these patients giving up by going to the treatment? That was the thing. I'm giving up work. I have to work. That's why I can't go. I'm giving up, having to care for these family members to be able to go. So those opportunity costs were a big factor for many of the patients. And so just as overall, this means that there's a lot that's driving behavior in this system on both sides. And so being in the healthcare system and talking with people about cardiac rehab and incentives and everything, one of the things that I learned is that there's just some things in economics that I hate. And one of them is this term, skin in the game. I don't know if I'd come into contact with this before talking to people about incentives, but I would talk with people in the medical system and they'd say, well, you want people to be invested in their care. You need to make them pay some for it, or they won't be invested. They need some skin in the game, or they're not going to just really be invested. And anyone who knows anything about preventative medicine and trying to get people into it, this is just completely wrong. You don't want to put any barriers between that patient and accessing that care. It never turns out well. It's the biggest way you're going to drive down use of that behavior. And so one of the ways that I saw this really well demonstrated was in this paper that was senior authored by one of my good friends, Quinn Pack. He's a cardiologist over at Bay State. And what he was doing was looking at specifically, what does this do? If we have cost share, what does it do to people attending cardiac rehab? So what he did is he looked at about 600 patients that had entered their cardiac rehab system. So they at least enrolled in cardiac rehab, and looked at how many of them had cost sharing, how many of them either had copays or they had deductibles that they had to pay for before they could access their care. And so 39% had some form of cost sharing. 82 of those were copays, 34% were unmet deductibles. And what he found is that any form of cost sharing was associated with attending 6 fewer sessions of cardiac rehab. So it didn't matter what it was, if there was something there, that was already knocking 6 sessions off. And if you looked at the people that had those unmet deductibles, as the ones that got enrolled in November or December, and that deductible is rolling over in January, you got to start again. That was, kicking another 4.5 sessions out of it. So he, did this analysis and looked at, if we adjust for those baseline differences, we find that every $10 that you increase people's, payment to get into cardiac rehab, that's 1.5 fewer sessions that they'll attend. And one of the interesting things he found is that household income did not moderate this effect. It was independent of reported income. So whenever someone tells me about skin in the game, I just bring out this paper and say, no, do you want people going to cardiac rehab or not? Make it as free as possible. So if I could change policy, I would say, let's no copays for cardiac rehab. All right. So when I was talking about contingency management and cardiac rehab, then of course I have to go through and see, what has been done, because we did these great studies on contingency management, and you always think you're like the first one to do anything, right? And that's never the case. And so after we did some of these studies, I went back and was like, hey, people already did some stuff with incentives in cardiac rehab, because as other people have mentioned, it's actually much more common to see some incentives being used in some, in businesses or other health systems. It's actually a relatively common thing, although not often maintained. And so I just found a couple examples that I thought were really interesting of how people had used incentives in cardiac rehab before. All right, so this is another one that, again, this is Quinn again. Back in, let's see, 2013? So he had done a quality improvement project that included incentives. And so he was looking at his number of cardiac rehab sessions attended and saying, oh, this is not good. We need to get more people completing more sessions. So what he did was actually set up this quality improvement program. And the last step was incentives. So there were patient-based incentives and there were staff-based incentives. So both groups were given these little punch cards. And when they did the things that they were supposed to do, either completing more sessions or, let's see, for the staff, it was things like showing people educational videos, or if your patient got a reward, or, you got someone back in that had dropped out, and you got a little punch on your punch card. And each 6 punches, you got to have, some fun thing, water bottle, t-shirt, whatever. And so this was part of an ongoing quality improvement project that he did. You can see it's the last one over there, period 4. But you can see with various improvements in what they were doing, they were able to increase the number of sessions that people were attending. And there was another fun little one I found that was this was specifically looking at the feasibility of using financial incentives to increase exercise in Canadian cardiac rehab patients. So this was senior authored, I thought Phil, oh, it was Dr. O's in there somewhere. But this was done up in the Toronto system in Canada. And I thought this one was fun as well. So once people complete cardiac rehab, you want them to maintain their exercise after they leave, and that's difficult. So this was aimed at that. So people were enrolled in a 12-minute maintenance program after they had completed cardiac rehab. And they got these self-monitoring diaries, and they got $2 for each day that they completed their exercise diary. And then they could redeem these rewards each week from a list of vouchers that they had available. And popular ones were the grocery store, and then also donating money back to Toronto Rehab. Those Canadians, they're very generous. Okay. So I just thought this was very interesting, because this was much about getting the acceptability and feasibility, looking at from the patient side, what they thought about this. And so, over half of the participants said that they were very likely to sign up for this program. And this increased to 74% if they were allowed to donate their earnings to charity. But from a data standpoint, this was what they found was really nice, actually. So the people that were in the incentive condition actually maintained their cardiorespiratory fitness following those 12 weeks, whereas those in the control condition, their CRF dipped down a bit. So that's what you want to do. You want to keep that CRF up. All right. So now I will go formally over to the work that we've done with contingency management in cardiac rehab. So the first study that we did was looking specifically at incentives alone. So what we were doing here is trying to improve cardiac rehab attendance and adherence among lower socioeconomic status patients. So this was, early on in my time as faculty at VCBH, and I had the privilege of being mentored by both Steve and Phil. And so I just lived in this world between them of incentives and smoking and cardiac rehab, and just did everything there kind of at the conjunction of that. But this was a trial that was funded through our COBRI. So what we did here is that we randomized 130 lower SES patients who are eligible for cardiac rehab. So these are patients that had a CR qualifying diagnosis. So this is myocardial infarction, bypass, PCI stent, valve surgery, chronic heart failure, certain signs. And our lower SES marker was they were insured through Medicaid. And they were randomized into one of 2 conditions. It was just usual care, or you can earn incentives. And we stratified them by smoking status and age, because those are the 2 strongest predictors of cardiac rehab participation in the sample. All right, so these incentive schedules should look very familiar to you, because I think you've seen about 3 different versions of them in the last 2 talks. But the incentives were contingent on completing the cardiac rehab session. So this was mainly about completing that structured exercise that they were supposed to do, but they also had to complete any sort of educational requirements that were were placed for that session as well. But it was an escalating schedule. It started at about $4, went up to about $50. Total possible incentive earnings for this was about 12 weeks, 3 months, was $1,238. In this study, we got to pay people out in cash, which was fun. And there was a reset in there for unexcused exercise visits. All right, so the participants that we got were really representative of what we consider a high-risk population. So if you look at the age in this sample, it is 57. That is about 10 years younger than the general population of cardiac rehab. So obviously these people are coming in almost a decade earlier because they have accelerated disease from the various behavioral risk factors associated with being lower SES. One of those, of course, is that they had high rates of smoking. About 40% of this sample was smoking at the time of hospitalization, and they also had considerable rates of psychiatric and medical comorbidities. One of the interesting ones is that when we look at fitness level, so the patients in this study, the Medicaid patients, had a fitness level that was equivalent to someone who was 10 years older than them. So this 57-year-olds may have been 10 years younger, but they had the same fitness levels as the 67-year-olds. So they also had high levels of depression, anxious symptomology, and also they had elevated problem scores on self-reported executive function measures as well. So this was our primary outcome from that study. On average, participants earned about $700. They completed significantly more cardiac rehab sessions, so 22.4 versus 14.7, and they were almost twice as likely to complete cardiac rehab. So the graph there is the number of people that are still engaged in cardiac rehab over the course of the 36 sessions. So you can see the separation as we get closer to 36. One of the things, this is one of my favorite papers. Oh man, you can't see the lower blue lines. I was going to say, this is one of my favorite papers that I wrote out of this set of data. So we were talking about discounting, so I brought it back so you could all look at discounting data. So as I mentioned, we did a bunch of executive function measures, and one of the measures we took was to delay discounting. So I was looking at this data and thinking, what if we look at this by whether people are steep or shallow discounters and see what happens? And you get this beautiful interaction. So these are our people that discount steeply, and you can see if they're not in the incentives group, they drop out fast and hard. Whereas if they're in the shallower discounting, then they're right down here. So it's a really clean interaction of discounting and incentives. So if there's ever a group to appreciate that graph, I think it's this one right here. All right, so that was the first study. Thanks to the results from that, we were able to submit an R6133 that was funded through NHLBI and look at further into this issue of whether we could improve cardiac rehab adherence among these lower SES patients. So what we had thought about is, we did a really good job with the incentives, but could we do better? I mean, getting people to complete, 50% of the group to complete all the sessions is great, but can we do better? And so this trial was inspired by work that Steve had done looking at what you could combine with contingency management to further improve outcomes. So for this one, we recruited 209 patients with, again, lower SES and a CR qualifying diagnosis, and we randomized them 2 to 3 to 3 to 3. We under-enrolled our control a little bit to one of 4 conditions. So we had our usual care, and then we had our incentives only, but then we also wanted to look and see if we added an element, which we here called case management, would that improve outcomes further? So this is based on the community reinforcement approach that Steve worked on, is if you combined incentives with that community reinforcement approach, then not only are you reinforcing the behavior, but you're also putting in those additional behaviors that would help support the behaviors you're looking for. So in this case, the equivalent of it for the health field was case management, where you have a nurse case manager who works with the patient and figures out what are the barriers to you accessing cardiac rehab, what are the other things you need to do in your life to help support you in having behaviors that improve secondary prevention and get you towards that goal of recovering your health. All right, so our primary outcomes for this were the number of cardiac rehab sessions that were completed out of a total of 36, and also looking at the number who completed 30 or more. So very similar incentive condition, and we just happened to start at $10 and go up to $40 this time instead of starting at $5 and going up to $50. The total was very similar at $1,220. This time we had to pay out in gift cards because people were concerned about us using cash from a legal perspective for some reason. And it had the same reset. All right, and so this is the case management intervention that I was mentioning. So our case managers, they did an initial needs assessment where they met with folks over the phone to talk about medical, social, psychological, practical barriers to engaging in cardiac rehab. They engaged in weekly goal setting, helping them identify and overcome those barriers, encouraging them to reach their goals, and then they were available to, as needed, to answer for any acute needs. And this is just what that looks like. They were randomized. They did a brief meet and greet in the hospital, and then they did their needs assessment, and then they did weekly check-ins, and this time they were available by phone. All right, so our participants, I'm not going to dwell too much on this because they were very similar to the first group. Once again, young, same high rates of smoking, same considerable medical and psychological comorbidities. All right, so here is the attendance data from that second trial. You can see once again, this is the same type of graph where everybody starts participating at session 0, and then we're interested in how many people make it out to either 30 or 36 sessions. So down here, the gray line is our usual care. The blue is our case management only. This yellowish is the incentives. And so if you look at the difference between the incentives and the usual care, that gap is almost identical to the first study. And then what we found is that even though case management alone didn't really move participation, the combination of case management and incentives was even more effective. So we look at the odds ratio of completing cardiac rehab, and we see that for the incentives alone, the adjusted odds ratio is about 5. And then if you look at the combination, that odds ratio is actually 13.2. All right, I think I've been going through here at a fast enough clip. I can do my moves back to behavioral pharmacology. I mentioned I wasn't going to talk about substances, but since I do have a little time, I am going to talk about substances because I'm going to move back to smoking. So we've gotten a little smoking. We'll go back to smoking. So as was mentioned in the sessions yesterday, I don't think we need to talk about the dangers of smoking to anybody in this room, but I just wanted to reemphasize that a lot of the early mortality and the morbidity that we see from smoking is due to heart disease. So this is the biggest mechanism through which smoking kills and hurts people. But from my perspective, what I wanted to look at was kind of the interaction between smoking and these other behaviors I'm interested in. So I spent a lot of time also those last 10 years looking at how smoking affects other cardiac related behaviors. And I'll just talk briefly about some of them. So one thing I wanted to mention is that about 10 years ago, I think because this isn't a special issue of PrevMed from 10 years ago, we did what I called a systematic review, but is Jamie here? Can I apologize at her? No, she's not here. This was my first attempt at a systematic review, and I think we actually ended up calling it a systemized review because we didn't check all the boxes really for the systematic review. But what we wanted to demonstrate here was how does smoking affect these different cardiac rehab metrics? And we looked at referral, attendance, and completion. And then there were some interesting things, like if you were currently smoking, your chances of getting referred to cardiac rehab were actually higher. But looking at attendance was lower. And what we really saw was that people who were smoking dropped out of cardiac rehab. They might enroll, but then they were gone after a week or two. And so this is just the table from the completion of cardiac rehab and smoking. And so it's a very strong predictor of people not completing cardiac rehab. And I will say that we've duplicated that effect with our own data. So I was fortunate enough to be allowed to do one of the first analyses that came out of this CR registry. So AACVPR, which is the National Association for Cardiac Rehab and Pulmonary Rehab, has a database that they use for all the CR programs that are affiliated with them. And they opened it up for research questions a year or two ago. And Katie Menson and I got to put in something that was accepted as the first thing that they looked at. And so what we did was look at the effect of current smoking on what was happening in cardiac rehab and pulmonary rehab. And one of the things I would just say, none of it was a real surprise, right? The people that were currently smoking were younger, they were lower SES, they had higher rates of psychological symptoms, they had lower fitness at entry, all those things. And the two things that I will just highlight is one, once again, we're seeing that there are fewer sessions of cardiac rehab attended by people that were currently smoking. I think it's about 5 sessions different there. And then when we look at people improving during cardiac rehab, the people that are currently smoking improve less while they're in cardiac rehab. So here we have, if you're currently smoking, you improve less on your 6-minute walk distance, on your METs, which is a measure of cardiorespiratory fitness, and you also have higher depression scores at exit than if you had not been smoking. And just to put one more mark on that, we also looked at that current smoking and its effects on improvements in cardiac rehab, specifically within the UVM database. So they had over 2,000 people that completed cardiac rehab, and they do these gold standard measurements of CRF. And so we were also able to look at the effect of current smoking on improvement in CRF using gold standard measures. And we found the same thing. And so just to orient you to this, once again, losing some of the error bars, but at least you can see the lines. So this is improvements. So change is over here. So higher is better. This is how old people are. So over time, when you're older, you improve less in your cardiorespiratory fitness, no surprise. But the lines are your smoking status. So here is current smoking down here. You just shifted. Your improvements in CRF during cardiac rehab just shift down. And there's not actually a whole lot of difference between the never smoking people and the former smoking people. Once you get past a year or 5 of smoking, you are able to improve your fitness just about the same as if you were a never smoker. So this is why I always tell people it's never too late to quit smoking from a cardiovascular perspective. The cancer people have a different perspective, but from the cardiovascular perspective, quitting anytime is good. And so this just brings me back to the, I would love to further tackle smoking in the population of those with cardiovascular disease. And so I'll just bring it back to one last little contingency management project. So this is a study that was done by Sully Coleman. I don't think he's here anymore either. Sully, giving you a shout out. So he did this project that I consulted on, I guess, looking at trialing contingency management for smoking cessation in people either with cardiovascular disease or cardiovascular disease risk factors, doing home-based CM. So bringing it to the people. And it was really interesting because, there's a lot of acceptability in, for the people that are homebound or unable to access resources coming to the clinic, how can we come to them? The remote you heard about, this is another version, the home-based. But, this was, pilot trial, but it showed nicely that if you did incentivize smoking cessation, you could get beautiful reductions in CO measurements in this population as well. All right, and I will just wrap up there. Say thank you, everybody. Thank you to, this is the cardiac rehab team, and thank you to everybody. I'm sure I forgot somebody, but those are a lot of folks that were really key in all of this.
You do it all. I just noticing that we needed another.
Yeah. Take that.
That's what happens when you stuff 4 of us in one.
You'll have to share the microphone, but that's okay. Thanks for another great set of talks here to wind up the conference. Got a long line of people, all you diehards. And we have plenty of time too, so please, Sandy, go ahead.
Thank you so much for all your presentations.
Okay.
I have a question. I guess it's maybe for Max and Steve. I thought it was really interesting that, in your study, Maxine, where you provided incentives for both opioid and cigarettes? Alcohol.
No, alcohol, yeah.
Alcohol and other drugs.
illicit drugs.
Yeah. So in the naltrexone studies that I ran, if people stopped using opioids, they stopped using other drugs as well. So if you did not incentivize people about their other drug use, would it also still just go down if their primary drug?
Well, that's a great question, isn't it? And so the parameters and the contents of this intervention were designed by the dynamic care people. They had their own reasons for doing it the way they did. And a lot of it, I think, had to do with appeal to the clinicians who would be involved with it, who would have, I don't know, appeal to the healthcare providers or the health community that would be using it. This is why I was trying to say something about how this digital therapy could be used in research to disentangle all these kind of questions that I know everybody has. I have them in my head too. What if you took away the incentive and only incentivized the alcohol? You see, and so I don't know. Now, some of the research data that was done with in-person delivery showed that if you incentivize abstinence from drug A, you get a reduction in drug B as well. In fact, I remember one of Nancy Petrie's early studies. She was incentivizing alcohol abstinence, and she took a look at the illicit drugs, and they went down.
Yeah.
On their own. So yeah, it could very well happen with the digital therapy too.
It's just so interesting that that happens, because like, why? Why does that happen?
Well, in this case, they were reinforcing the negative.
But only the primary drug.
The primary was alcohol. But if you see, this is one of the little interesting features of this particular version of their therapy. $10 was going for negative alcohol and 10 for negative drugs. So the people who weren't using drugs in the first place were basically getting $20 for alcohol.
Well, I'll just add a little piece that's kind of, we never really got to do an experiment on it, but back when we were treating cocaine use disorder, a large proportion, more than half, also had alcohol use disorder, but we were focused on cocaine use disorder. But if there was another problem we thought was functionally related to using cocaine, we would try and do something about it, but we didn't use CM. So we used disulfiram for alcohol, and we noticed and wrote a letter that was published, I can't remember what journal, saying, hey, treating cocaine-dependent patients who have an alcohol use disorder, which is most of them, you'll get a reduction in their cocaine use. Right. But it was in my opinion, what I think, because you want to know, well, how would this happen? I'll give you my interpretation. But the interpretation when people read that was there was something through dopamine and whatnot. What I think happened for a lot, it's just you kept them from going to the bar. If they couldn't drink, a lot of other things, the risk behaviors that go along with drinking were less likely. That's how we thought about it, and that's why we did it. But I think it never really got researched like it should have been, because the interpretation was so different than how I think it was working.
Interesting.
But just to follow up, I can yell out.
Oh, you can. The only problem is they can't hear you online. Yeah.
I know you didn't count cannabis as an illegal drug there, but did you get cannabis data?
I'm sorry, say that again?
You didn't count cannabis as an illegal drug to reinforce.
Oh, have we looked at the
Do you have the
cannabis data? I don't think it's been looked at yet. Sorry.
I don't even know if the saliva tests are very good, honestly, for cannabis.
Yeah. Right.
Yeah. Because of course one could ask, did that use go up with everything else going down? I don't think so, but possibly.
I was just going to add, I was going to add that, so one of the secondary analysis from the scenic data, right, was looking at reductions in alcohol use, right? That the people that were assigned to the very low nicotine cigarettes also had reductions in some alcohol use, like risky alcohol use. So I think it's something we see a lot, this, cross product interactions.
Well, and very often when people were reinforced in the cocaine studies who were also using opiates, there was reduction in the opiate use as well. Could have been because of speedballing or other factors.
No. Oh, yeah,
A little technical break here.
I think it's coming.
I have some very disconnected thoughts that I was hoping that you would help me connect them and just wanted just to see your reactions on it. And then I have some questions for Stephen. So before coming to the US, I think I worked in the largest conditional cash transfer program in the world, the Brazilian Bolsa Família program. It's the largest contingency management program. The Bolsa Família program is like 21 years now, and it's focused, for those who are not familiar with it, it focused on families, and they receive small incentives for taking their children to school and healthcare appointments. The program is very focused on, it has a family-based approach, and the idea is to invest in human capital. So I'm wondering, what are the opportunities that we have to kind of integrate and address substance use behavior within that program? Or do you know of any family-based approach to contingency management trying to address substance use? We know that some of tobacco policies are like focused on next generation, so this is another disconnected thought. And also, could we do something at the college level, because we know that young adults are there, so could be a place like the schools in Brazil. They play a very essential role in monitoring those behaviors. So could something be done at the college level? So these are the thoughts that I have thinking about the big picture. And then for Stephen, I recently submitted an application on gestational diabetes. So I was listening to you and wondering several things. Do you control for that in your studies? We know that tobacco use is associated with higher risks for this gestational diabetes. We learned a little bit about all the cognitive burden of like women trying to decide and learn what they need to eat. The devices that they have, and with the continuous glucose monitoring, is there a dose response association between maternal smoking and neonatal outcomes? If those moms don't show abstinence, do you know of any, I don't know, smart trial that for those who fail, they try to reduce? Is it worth trying it?
We did not control for gestational diabetes in these trials. Off the top of my head, I cannot think of whether we recorded that during the trial. I don't remember doing so. The only thing that comes to mind is we once did a trial trying to incentivize women who were pregnant and I think already overweight or obese, and the OBGYN was the lead, and we wanted to try and keep them within the recommended weight gain parameters while pregnant. One of the side effects would be risk for gestational diabetes, and we were unsuccessful. And it was primarily a clinically focused OBGYN. So to my knowledge, she never followed up, and I just didn't feel like I had the expertise to do that. But that's the only thing I could think of in that area. But I think, I don't know a lot about it, but you probably know more than me, but gestational diabetes is I learned in that, is a serious outcome, because the women who have gestational diabetes are then more likely to have type 2 diabetes going forward. So it's not a minor thing, but keeping the women in that band of weight gain during pregnancy, which was pretty narrow, we
Perfect.
didn't accomplish it.
Okay, okay. Do you, I couldn't, maybe I missed it, but do you continue the contingency managed postpartum, like during breastfeeding?
Out, we continue the incentives out to 12 weeks postpartum.
12 weeks, okay.
Yeah, and we used to get, it's interesting, if you do these repeated trials with any of these populations, things change over time. We heard it, like what drugs people are using, but what initially, by getting women to abstain from smoking, we got increases in breastfeeding. And we wrote several papers underscoring that. And then eventually that outcome, we stopped getting that improvement. But what had happened is, I think early on that that the practice was to recommend to women who were smoking that they not breastfeed. And then ACOG, which is the organization recommends
Right.
Obstetrical practices, said no, the benefits would outweigh the risk. And so now then the nurses start recommending, you should breastfeed even if you are smoking. And so we lost that effect. But smoke, yeah, I'll stop there. But I was very interested in smoking and breastfeeding. And then somehow that waned. And part of why was what I just said, but there's probably some direct effects I can't remember off the top of my head.
Okay.
On breastfeeding and smoking, but I can't remember it all. We wrote some papers and some book chapters that are in the literature on
Okay.
that topic.
Okay,
Yeah.
thank you.
Can I add to that?
Yeah,
So-
please. Yeah, there we have an expert. Go ahead. Sorry, I should have pointed it all to you
Yeah,
from the beginning.
We have done good amount of research on smoking and breastfeeding. So one of the potential biological pathways, like we know smokers have lower breast lactation hormones, like especially prolactin. So that means you don't have enough hormone to produce breast milk. So that's a good pathway. And also we know like smoking can impact the mother's nutritional status, as you mentioned. The weight gain is one of them, but also other like lipids as well. Basically, even for the mothers who breastfeed, when they smoke, the milk, the components in the breast milk in terms of the nutrients quite different from the mothers who don't smoke. So in that also, that breast milk is kind of bitter because of nicotine there. So the babies may not like their mother's breast milk because of the differences of those chemicals in their breast milk. So those things may play a role there in terms of why we see the smoking mothers tend to have a lower breastfeeding rate and shorter breastfeeding duration.
Yeah, very good.
Okay,
Very
thank you.
good. Thank you.
Yeah, and does anyone have thoughts on the bigger picture question?
I mean, I think the world of the conditional cash transfer program. So this is a program to the World Bank decided they were going to try and use incentivize to combat chronic poverty. And I swear, I can't get Ken Silverman to verify this. He says he doesn't remember. I remember getting a request from them for our studies on CM for cocaine use disorder. And then I sent them what we had. I never heard back from them. And then we saw these studies and they started in Mexico and they went, and in Brazil, they had an amazing impact. So they incentivized getting women, especially girls, enrolled in school and keeping them in school for, I think, at the point where they reach puberty. And it changed the, survival rates in infants in Brazil, but then it went through Africa. So there's some variability, but
Yeah.
I was impressed.
Yeah,
It's
and
an
I know
amazing
some
program.
countries are very open to doing research with their programs. I did research with that program in Brazil, but I know the Brazilian government is not that open, but I know that the Mexican government is very open. So I wonder, and we have, these programs really have the way to implement it,
Yeah.
right?
I'd
It's
be all ears,
massive.
because I tried to contact the World Bank saying, I remember sending you these papers. I never heard anything back. I didn't get any response. And I suspect, like you were saying about Brazil, that, you know, there's some sensitivities to it because it's done population wide. And,
Right.
but I'd be very interested if you had relationships in Mexico. I think it's an amazing program. And those are the guys that kicked it off.
Yeah.
As far as I know.
Yep.
And in one review paper, and I think it's in 2012 special issue of Preventive Medicine on Incentives in Health, we have a paper, if you haven't seen it, written by people who are active in the in that program, not but the conditional cash transfer program, and they talked about the relationship to contingency management in that paper. So you might have a look. You can tell if you Preventive Medicine has a page that lists all their special issues. So it's 2012 Incentives in Health,
Okay.
and you'll be able to tell by the authors who wrote and by the title, as I recall, that it's on conditional cash transfers.
Okay.
But there should be a much more of a connection between what we do here on CM and what they're doing.
Yeah.
But it's not established yet, but maybe you could make it happen. Or, you know.
Yeah.
Yeah.
I
with
think
some
there are
program.
a lot of opportunities there for sure.
Yeah.
Thank you.
Yep, thank you.
Hi, so I've been getting involved with the rollout of CM in Kentucky, and I had some questions. Mostly one, I just kind of wanted to get your opinion, and I might be overgeneralizing a little bit here, but there seems to be like two kind of approaches when it comes to rolling out CM, like in various states. You have one, it's the Nancy Petrie and Carla Rash kind of inspired clinician implementing CM in a clinical setting. They're the ones who are responsible for delivering the incentives and managing them. And then you have a vendor like Dynamic Care, a company like that, who they're the ones that are really handling, they work with a clinic, but they are the ones that actually manage and deliver the incentives. Do any of you have any opinions on pros and cons of kind of each one of those approaches, or if you think one is better than the other? Just kind of looking for some thoughts and advice.
Well, first, I think it's a little too early to compare them because there hasn't been very much experience yet with the digital therapies. Some of the potential pros and cons are kind of theoretical things, like I mentioned in the talk, that the remote testing with the digital therapy gives you this much wider window of opportunity to request tests, which would give a more valid picture, theoretically, of the actual drug use in the real world. No, I mean, there are probably pros and cons to each one.
I can add a couple thoughts. So yes, there is the approach of the clinicians delivering it to their own patients, and then there's the researchers and or external companies that take over the testing and the delivery. And so one of the things that with the clinicians is they either are so invested and have the time and want to do it themselves, or they have no time and don't want to be involved. So I think it has a lot to do with what setting you're in and what they have as far as resources. Because when I did the contingency management cardiac rehab stuff, that was all done by research staff. But then when Quinn did his stuff, it was all done by clinical staff, because he had the perspective that he wanted the clinicians to be the ones in there doing it and everything. He wanted them to be invested, but then you also have the clinicians that don't have the time and don't want to be invested. So I think there's lots of pros and cons to both sides.
And my recollection is that the majority of the studies done in clinical settings, it was research assistants who were actually running the study. So
I want to give Tyler a chance, but I have a comment, but Tyler might cover it. So since this is what he's working on.
good.
Yeah.
I can try to speak. So yeah, I mean, one of the things trying to always keep up to date with is who's doing what, where. To my knowledge, if Rick's on the call, he knows too, but I don't believe there's Delaware or Rhode Island is using Dynamic Care as part of their statewide rollout. But other than that, they're all in person. And like with California's, it's entirely in person, primarily in specialty care settings. the individuals who are delivering CM actually varies quite widely depending on how the program's set up. So peers can be included in California's, which is actually a little bit different than even some SAMHSA guidelines. But I think by and large, it's all in person. And, one of the pieces that comes up through, here in Vermont in our rollout, in the California rollout, is there's an interpersonal piece to coming in and being able to talk with your CM coordinator or the person that's running these visits. In theory, they're 5 to 10 minute quick visit. Like all the state rollouts so far, it's CM as the intervention and nothing else is required for someone when they come in. It sounds very transactional, even before the providers, before they get started. Like, okay, someone's going to come in, we'll schedule 5 minutes for their or 10 minutes for their CM visit, and then they'll be out the door. That's the case for some. Some people want to talk as well. But I think one thing it's trying to talk about and capture that it can be done, just haven't figured out really how yet, is there's a social component to these visits. So people will report, not only is it the incentives that are wanting for them to want to come in and doing well and the success, the enthusiasm that the provider has for when they come in, knowing these individuals for years and the struggles that they have. The money, some people will report the money's great, but the success and feeling like I'm succeeding in a program when for oftentimes a lot of individuals, they're not receiving a lot of positive reinforcement or haven't historically seen it for other places. That piece to capture that electronically or remotely is going to be more difficult.
Well, and I was going to comment on this in the discussion. I think that's one of the reasons that Dynamic Care started including this peer support option within their program. Because, so I said, okay, research assistants were running it in the clinics, but they were providing support. They were the cheerleaders, and people really appreciated meeting with those folks and having the social reinforcement along with the money. And so I think that I think plays probably an important part, and it would be good to do a study, in my opinion.
I'll just add the one potential,
I want to sober things up a little bit, Sean, and that is you got to have uniformity across. You have to have a protocol, or you are going to have a lot of variation you don't want, and probably less effectiveness. You just let the clinicians make it up. I wouldn't be too optimistic. So I think,
I will just give the one potential con, right, to the clinician being involved. So if the potential downside there is if they're not doing well, if they're not getting the samples that they want, is that going to impact their care and their relationship with the provider? So that's just the potential downside of having them enrolled. So it's all good if they're doing well, but what if they're not doing well? It depends on how the clinician handles it. So
because the research assistants were always trained on how to handle that situation,
right,
to be kind and supportive and better, let's try again next time.
Yeah, and I mean, as part of the training materials, they're set up so that how do you handle, and there's role plays for how do you handle when someone provides a positive result. Because you don't want it to turn into functionally a punisher and then you never see them again.
Right.
And I can speak at least anecdotally to some of the data from Californian providers here. There are individuals that have participated in the CM program for 24 weeks and not provided a single stimulant negative UA across the entirety of it. You would ask, why are they still coming in then? Well, and I think the question that it brings for me, at least from the research side, is why are they still coming in? Because there has to be some other component that we're, like some other reinforcer.
Yeah.
Maybe it's the fact that they're being able to talk to someone. Maybe it's twice per week. They have 10 minutes of someone's time to be able to just check in and see how things are going.
I like all of that, but I'm going to push back a little bit, man. There's a reason management is connected to contingency management. And if you don't have a consistent application of the contingency, you're going to get crappy outcomes. And so that doesn't mean that you can't have different clinicians depending on the clinic who are involved or whatnot, but there has to be a protocol, and there has to be, I think, I haven't run any experiments on this, but I think I could guess the outcomes. But I have seen people mess up contingency management by overlooking the management side. You know, like, oh, well, they're a nice person and I know they're really trying, so I'll give them the incentive anyhow, even though they had a positive urine or whatever. So I don't know what you're looking at, but and Tyler, you're involved in California. My understanding is there's a lot of variability, but there's a protocol and there was a lot of training in all the different clinics about that
Yeah,
protocol.
it's very training driven. And even when I'm talking about like with the individuals that are still coming in, they never earn the incentive. Like they're coming in for their visit and they've never been.
But just in terms of the program, setting up a CM program, which is my understanding, that's what you're trying to do in Kentucky, right?
Yeah, I mean, the Montana and Washington data are coming out and like it's clinician implemented. There's a lot of drift and treatment fidelity, and I think that's a big concern.
Yeah, it should be. It should be.
See, I just assumed that all these state programs would be run with a protocol.
Too many years in research.
They are all run with a protocol. I can speak to that. I work with Mike and Sarah directly. They have a very good protocol for all these pieces as well. I think, yeah, what you're experiencing and was talking with Greg for just what you're experiencing is drift and turnover. And we're talking about a service delivery system that you're constantly training new staff. And
So that's an advantage of the digital systems, right? Because they're pre-programmed and everybody gets the same thing.
Yeah.
Right. So I have a few questions, but I will start with two, then to see if other folks, finish how much time we have. Yeah, my first two questions actually for everyone. I'm very glad to see the promising results, across all the studies you cite. So that gave me a lot of hope. I feel much better than yesterday, when we see a lot of problems. Now we have very consistent, treatment that can help a lot of people with different disorders. So my first question is about the schedule of the incentives. So looks like there's a pretty good variation in terms of how much money should we start, and also how much we should increase, right? So I see some folks use $10, some folks use $25 to start with. Some folks increase by $2 for the next activity. Some study use the $5. So some cap like $50, some cap
saying it's painful.
Oh yeah, sorry. So the point is that when you guys design those schedule, I assume you give them very careful thoughts, right? Can you share your thoughts? What kind of things you consider? What's the reasonable schedule to use? Thanks.
I will give the example about why my schedules were a little wonky. So I based them off of Steve's schedules, adjusted for inflation, I think is what we did. But I was also, having to work with Phil and what he thought should be done. And so, for example, he thought that the first couple visits were very important, that if you got people in the door, then that would be the really important. So for a couple of our studies, the first session was actually incentivized more than other studies. And that was that was using the science, but also trying to compromise with the clinical program that I was implementing it with it.
I remember well, go ahead, Maxine, you start. You did much earlier work than I did, so go ahead. Yeah.
No, you go.
Okay, so I remember it's a long time ago now, 38 years ago or something, but when we were doing cocaine, trying to set up the proposed schedule and the grants for cocaine, we thought a lot about what the cost of cocaine was in the street at that time, how, what the potential earnings, how they compare to that, those sorts of things. And then the half-life of the drug you're trying to measure and how often you have to measure, so you're not going to misuse and thereby get noise in whether they're only earning the incentives when they're abstaining versus not using. So we put a lot of thought into it, and then when we moved from cocaine to pregnant women, we leaned a lot on what we had learned with the schedule and whatnot with cocaine. But the reason I jokingly told you to stop about all the different is we have not done as a field, and I can say more why, but I think we didn't have the support to do the parametric studies, which would generate the consistency that you think we should have, and I agree. And so that we just need parametric trials.
So, Nancy Petrie did that a little bit, and she had her $80 versus, I forget what the Heil one was, but 230, yeah. And so that was nice to have. That was at least set some boundaries. I'm just going to make a joke because I'm glad to hear that you put so much thought into those early schedules, because I always thought that the reason you did it is to just have a total amount that sounded good to people, and that was going to be what sold your program.
Especially the grant reviewers. But
You
I was
paid
gonna say-
$1,000.
the thing was, I can remember Tom Crowley in particular, laughing at the idea. You think these people are losing their wives and their houses, and you think you're going to get them to stop using cocaine with $1,000? Soon as you get a treatment effect, who's going to pay $1,000 for that? So, so just go into it anticipating no matter, like, you're going to get criticisms no matter what. But I think, I don't remember, when you're writing a grant, you have all kinds of factors you're considering, but I do think we gave some thought to it, and especially, the frequency we were testing, and whether we had a meaningful incentive, and how we were going to try and discourage taking breaks, so that's where that whole escalating schedule, but with a reset. So we gave a lot, and then we did testing, like what to see. And I remember this more with the pregnant women and smoking. Can we pick up, with the urine tox that we were going to use? Can we pick up what we need to pick up in terms of smoking? And so yeah, we did a lot of basic background work, and as we moved on, like say to Diane's application, we were borrowing from the early studies, but
And there are practical things that you
Yeah,
have to deal with as well.
Yeah, I mean, I think one piece that run into often in working with states is, there's Carla Rash led it, and we had a paper talking about incentive magnitudes with CM and looking at all the studies and then seeing what that would equate to in today's terms across all of the year, taking them into account for inflation, like what would that look like in today's world? A 12-week protocol for a voucher-based model, you're looking at about $1,600 is what kind of in that medium effect size sort of range.
Yeah.
The piece we run into from the policy side is, this is where science meets advocacy meets policy, explaining to someone that the best, the science says we should be providing 18 to, Steve's original protocol would equate to about $2,400 in today's terms. Trying to persuade a policymaker to say that would be the incentive schedule, you have, there's the other practical side of, is that going to be something that they're amenable to, even though we know that that's what the best practice would say.
Yeah.
And so, I mean, I think it is, you have to sort of, there's a lot of talk about like a group, we're figuring out like how far can you vary from that? Because there isn't a strong science, and there's not, to Steve's point, the parametric study that you can show, to the point of like, here's the, because a lot of times states will say, what's the minimum we can do for this to still be effective? It's hard to like, what do you want to, like, what do you say as a scientist? Like, what am I comfortable with saying as a minimum? It's a hard, and again, the only piece that I'll sort of give a soapbox on is we would never offer to give someone a quarter dose of buprenorphine because it was more expensive. And so, like, when we think about this as a gold standard treatment for stimulant use and the way that it's being implemented, it's somewhat ridiculous that you're having to have the conversation of what's the effective dose. Like, why are we not arguing for the effective dose? And it's because it's the fact that it's incentives that are being provided.
I will just add one more practical issue. We run into issues of how much can you pay someone before you actually have to give them a W-9. And so that often becomes a cutoff for some people. It's like, what is it, $600?
Yes.
Something like that in a year. So if you go over that, especially with my Medicaid patients, that was hard. That's income that they have to declare that could interfere with their with their benefits. And so that was an issue. And the other reason that I went from 50 to 40 is because if I paid someone $50 a visit, I had to collect their social security number each time I did it. Whereas if I did 40, I didn't. So there's just these silly bureaucratic things too that sneak in there, and I'm sure just give Steve fits about how far we're going away from the science.
Yeah.
I think those are, you have no choice but to consider those, but I want to start out with those.
Yeah.
Like
Yeah.
why did we use large magnitude reinforcers? Because we thought if you don't get an effect, you're done. So
Yes.
start out with something.
Waste of time.
I think you could start out, whatever amount you is effective in getting an effect. One of the first questions you'll get is, could you do it for a cheaper amount?
Great.
You know,
So we have a Samsung like $700 for 12 months. I'm thinking like after hearing you guys talking about it, I'm thinking like say, can we use the artificial intelligence to kind of create a bunch of like candidates schedule, then have the $750 as kind of cap, then we need to add some parameters to the system, then the AI can help to us to kind of found some optimal, schedule that we can test out. I know like you guys give a lot of thought, but in terms like, I still think some decision are a little bit arbitrary, like based on personal, experience, whatever. But if you compare the medication, we have the, specific dose, how many times a day. So in this case, if we really want to move this to medicine, we do need to reach agreement, like what kind of amount, starting point, escalation, and cap and frequency need to be, more consistent. That's my point.
If you use AI, which I think is a great idea, and Evan Herman had raised that idea with me.
Great.
But you got to train the AI, right? So you'd still need those parametric trials, and then you'd be trying to feed the information.
Yes, great.
Right.
Yeah, my second question is really triggered by, very impressed by last study about using the case management to kind of boost the effectiveness of contingency management. So that's amazing,
I was going to say, go look at the CRA studies that Steve did, the community reinforcement approach, because that is what that is inspired off of.
Yeah, so that made me think like we have a similar scenario about pharmaceutical treatment for tobacco. Like we have nicotine replacement therapy, we have Chantix. So I know a lot of patients have adherence issue with those, like a lot of side effects there. Some people even don't want to use them for do not adhere to treatment. So I'm thinking like, can we combine the CM with pharmaceutical treatment? One is to improve the adherence to the pharmaceutical treatment. The other one is like, can we have this in synergistic, effect to boost the cessation rates? What do you guys think?
I mean, there have been studies looking at using incentives to improve medication adherence. So that is something which it is effective if you can objectively measure whatever it is you're wanting and actually reinforce it in a contingent manner. I don't think that anyone has done those two things synergistically, though, incentivizing smoking cessation and medication for smoking cessation at the same time.
They did a couple studies, but then didn't follow, when she came and gave her talk last month.
But was she incentivizing the medication?
No, she was not. She was just.
Yeah, so yes, there are studies where people have done incentivizing cessation and also provided medications for smoking cessation at the same time. But I don't think that the two behaviors separately have been.
Okay. Yeah. Great. Thank you.
We're down to just a few minutes here. Go ahead.
Hello. I am a nurse home visitor in Vermont, and I've worked in 6 rural counties for over a decade. And the smoking cessation piece, we do screenings and refer to 802 quits. And I've worked with some of the people that you've worked with.
Right.
And one of the issues is, of course, getting people to accept the referral to 802 quits. And so when I was hearing your presentation about the syringe, working with the community partners in the syringe replacement, and also with the case management as a value add to the intervention. I'm wondering if you've considered that with the perinatal population and the nurse home visiting program that we have in Vermont, which is in every county, and goes directly to the homes and works with women prenatally through 2 years postpartum. I'm just wondering if there's a way to increase adherence, and especially when we're talking about virtual options, young people today have so many different text-based, things happening on their phones that it might actually help to have that human component to help support that. And
Yeah, I
case it-
think it's a great idea and I regret, so Diane was hinting at it, like the first studies we published on CM for cocaine use disorder, we included this equivalent of case management with it, but it was a theoretically based case management. And then when I moved from that to perinatal smoking cessation, we left the case management, if you will. We didn't bring it with us, and I didn't know the population of women who smoke at that time during pregnancy. And then once I learned it, I thought, oh boy, I should have. But then we start doing systematic replications, and so we didn't want to change the treatment. But I think I still think it would probably give you better outcomes. I know you would get better health impacts more broadly if even if the smoking cessation wasn't improved that much. There are a lot of other things going on with those women once you start treating them. Now, if you're doing it remotely, you're not going to know that.
Mhm.
So I'm not sure about how we do case management remotely. But I think that the idea that you're playing with is an excellent idea.
Yeah, or how great would it be to integrate smoking cessation CM with the visiting nurses somehow?
Right, that's
Yeah,
exactly what I'm
that's-
thinking,
Yeah.
yeah, that it could be a value add for, certainly for your research.
Maybe it could be the remote CM in coordination, like Diane's saying, with the nursing group, and they do the
The onboarding.
Right,
case
so
management.
we did a lot of that. We would encourage them, support, help, sit with them while they called somebody that they were having trouble calling, or, those
Yeah.
kinds of like supportive.
Yeah.
pieces. Thank you.
Yeah, so thanks for bringing it up. Good grant idea.
Just two quick comments. This has been an extraordinary session at the end of an extraordinary conference. It's a celebration of what you've been doing and going from humble beginnings of schedules of reinforcement to amazing service to humanity. We've all been channeling mentors. My mentor, one of them, Dr. C. Everett Koop, the Surgeon General, would say, we've got to make it as easy to get the disease, the treatment, as it is to get the disease. And I think that goes back to, I was thinking of that when Diana was talking about the skin in the game stuff, barriers. The other thing is that he would say, if it works, do it. And we've got to figure out how to leverage what you're doing better.
Yeah.
And lastly, in the amazing people who help make this happen, who we've lost in the last year, Phil Aids and Warren Bickel and John Hughes and Roland Griffiths.
Absolutely.
I mean, what a testimony to what they brought to all this. So thank you all for making this happen.
Thanks, Jim.
Thanks.
Yeah, we're technically over. Thanks, Rhiannon. All right, one more round of applause for our last set of speakers here.
So I think I'm on now for wrapping up. And so this is the 13th conference we've had, and I've never had too much to say on wrapping up, and I think that'll be consistent here. I mean, we've just had two days of really terrific interaction and presentations, and I couldn't be happier. The topic that we selected for this year's conference, I believe in deeply. I think behavioral pharmacology has just done wonderful things and really robust and meaningful things, or had robust and meaningful impacts on addiction science. And I include, and I mentioned in my opening remarks, one of those is, being smart enough, my buddy Warren, to bring behavioral economics into behavioral pharmacology and addiction science. So I think, the panels we had were selected, not randomly, but with some pre-thought about what areas I think we've had, but there could be more, but those were areas which, I just think about the abuse liability testing and the FDA using the methods. And you know, how important that is and how it allows us to schedule drugs and what, like, if you didn't, that scheduling can be a pain in the neck sometimes, but no scheduling would be, you know, really dangerous to population health, public health. So, and then, you know, we talked about what if there was no buprenorphine uh, during this opioid epidemic. And you know, and I really appreciate Sharon's lecture in that it you know, was not exclusively behavioral pharmacologists, that's for sure. And Don Jasinski would never call himself. He said I think he would say he really respected and liked behavioral pharmacologists, but he wasn't a behavioral pharmacologist. But I will, you know, like a lot of people or some people in the audience, I was there when all this was going on and then tried to watch later. And I don't think without the experimental rigor of, you know, that George and Maxine brought to those trials and hydromorphone challenges and, you know, dose effect curves and all that sort of thing that behavioral pharmacologists are skilled at doing, I don't know, you know, how much longer it would have taken to get the drug to approval. So that's another one. The contingency management, I'm highly biased, but I think, you know, at this point, Jack really got me thinking about it. But just the breadth of problems that it can help with, you know, within addictions, but also like Diane was talking about other. And the funny thing we learned with Diane, these aren't different populations, you know. So I was doing cocaine or smoking, and Phil was doing cardiac rehab, but they're like, if you smoke a lot, you end up in Phil's clinics. They are, and so it's like this silo mentality. But so the CM, you know, can reach across disciplines, and so I think it's a beauty of it. And I think the CBT, cognitive behavior therapy, is a good exemplar of a behavioral intervention that's just really well regarded and thought well of, because it has those features. But yeah, so I would encourage us to you know, advocate and like we're all doing, but we could always do more. But I think CM is a terrific example of the contributions. The cannabis lectures today were really good. I think, you know, I don't know the whole cannabis field, but I remember when Alan and John Hughes were just starting, like, does it produce dependence? And, you know, John was just all said that's his specialty, or was a part of it. He had a lot of specialties, but that was one, is how do you go after answering that question? So that was a terrific contribution. And now when you heard the complexity or saw, like, it's mind-boggling what is going on in the world of cannabinoids. I mean, and how you study it. But I think the behavioral pharmacologists have a firm foundation to work from. So I think that's a great contribution. What am I leaving? What other panel that was in there I haven't mentioned? But they were selected. Each of the panels, I think, are good exemplars of important areas where behavioral pharmacologists have made some really impactful contributions. So I typically don't bring up the special issue of preventive medicine when you're fatigued like this and people think, oh, but you know, each of the people who gave an oral presentation at this conference will be invited to submit a paper to a special issue based on the conference. And I encourage you to think about agreeing to contribute a paper. And then I've definitely never said this before, but I want to say, I want to encourage you to be the first author and not to give it to, you know, your postdoc or your graduate student. Not that I'm prejudiced against that, and not that I won't hear, you know, suggestions in those lines, but across the 12 special issues, there's more and more of that happening. And then we have an editor-in-chief that's not as patient as the other editor-in-chief used to be. So I'm getting papers rejected before I've ever seen them. And a lot of times it's early career investigator errors. and that sort of thing. So if you're going to go that direction, chat with me about who you have in mind, that sort of thing. But I think we have the makings for a really good special issue that, all the things we liked about, just being together and talking about what we've done over the years, which has gotten to be a lot of years. I think having that in an archival, in the archival literature could be really helpful. Maxine, please join in. Yeah.
Magnificent conference is a great testament to the program that you, Steve Higgins, have built here at Vermont. I just want to sing those praises and feel proud that I was a little tiny part of that way back when.
A big part of it. A big part of it. Isn't it funny? We're all, have this comparable training histories in a sense of like applying for the postdoc or whatnot. And you say, the person says, yeah, you can, I can still remember you accepting my application and me being like staggered, really? But I feel very fortunate to have been included in this wonderful discipline. And, and a lot of it is kind of chancy, but thank you, Maxine. And I think BPRU, obviously you had a tremendous impact on me. And I think all of us most of us, I don't know all of us, but I would hope all of us who have gone through the BPR training program were influenced by the primary mentor, but also the other mentors. And like, my thought was if you go through that program and you aren't tapping the multiple mentors who have so much to contribute, then you're getting less out of it than you could. But when I was there, it was you, George, and Roland, and but it was a terrific experience. And then we have
that your program. So who was I talking to? We were saying that this program is modeled on BPRU. Was that you, Jack? We were talking. I don't remember, but.
Two of the three people who were making up our program were graduates of your program. So
right.
You know how that is. Like, well, how do you do it? Well, we've seen how you do it, and you just try and do it that way. Yeah.
But but thanks to you and your creativity, your innovation, your willingness to go, spread your wings and go, but into areas that you didn't start with. You didn't.
Oh, absolutely. Yeah.
And of course we all do that. Everybody does that when they're trying to fund their programs, but
yeah, I appreciate it. And I think what you just said is accurate. We get some mentoring and we get some experience, and then we grow the field. We do different things. I look at Sharon, she's down there making stuff happen in Kentucky, after years of doing it in Maryland at Hopkins. But, everybody's in Sandy, like she was mentioning, was in the preclinical lab. And I of course, remember seeing it at CPDD but that gave you a great foundation to do the work, your mastery of pharmacology, having worked with Jim Woods, and, you have a deep understanding, deeper than someone who didn't have, I think, some of that preclinical training. So anyhow, I feel very fortunate. I feel I share the sentiments that like I love this conference, that what we did the last 2 days. I had a blast. So it's been really fun. So I think that's all I have to offer. Thank you for participating, because it was this good because of all the good stuff you brought and shared with us. So safe travels for those of you who are heading back, and hope to see you again soon. All right. Thanks.